More than 46 million people in the United States have at least one of more than 100 types of connective tissue diseases, or also known as arthritis. Inflammation of one or more joints. These are categorized as either non-inflammatory or inflammatory. After completing this lesson, you will prioritize collaborative interventions for patients with osteoarthritis and rheumatoid arthritis. Teach patients how to protect and exercise their joints and conserve their energy. Compare and contrast the pathophysiology and clinical manifestations of arthritis and other connective tissue diseases. Interpret laboratory findings for patients with arthritis or other connective tissue diseases. Apply knowledge of pathophysiology to monitor for and prevent complications of total hip and knee arthroplasty. Rheumatic disease is any disease or condition involving the musculoskeletal system. Connective tissue diseases are autoimmune disorders where the body attacks itself. Characteristics are chronic pain, progressive joint deterioration, and decreased function. It may be localized or systemic. Osteoarthritis, also known as degenerative joint disease. The most common form of arthritis. There is a loss of cartilage in one or more joints, usually weight-bearing joints. It may be primary or secondary. Enzymes such as steromycin break down the joint cartilage. It loses strength and wears away. The joint space narrows and bone spurs develop, also known as osteophytes. Bone cyst and synovitis are common in advanced disease leading to joint deformity and immobility, pain and muscle spasm, and localized inflammation. The biggest factor triggering osteo is aging. Other factors are genetic changes, obesity, smoking, and trauma. Prolonged weight bearing contributes. Okay, let's discuss some terms. We have crepitus, a continuous grating sensation caused when irregular cartilage or bone fragments rub together, which may be felt or heard as a joint is put through passive range of motion. Also, a crackling sensation that can be felt on a patient's chest, indicating that air is trapped within the tissues. Heberden nodes, swelling at the distal interphalangeal joints in osteoarthritis that involves the hands. Bouchard's nodes, swelling at the proximal interphalangeal joints in osteoarthritis involving the hands. Joint effusions, excess joint fluid. Ballottement, a maneuver to detect fluid in the knee by grasping the medial and lateral aspect of the knee between the thumb and third finger and pushing down on the top surface of the patella with the forefinger. If fluid is present, the patella can be pressed down a distance and rises back up when the forefinger is removed. Clinical manifestations will be pain and movement limitations. Some of the prevention steps are to maintain normal weight, don't smoke, limit your activities that promote stress, limit participation in recreational sports, wear supportive shoes, avoid repetitive stress activities, avoid risk-seeking activities. Some labs that can be done to check for osteoarthritis are erythrocyte sedimentation rate will be slightly elevated, a C-reactive protein with secondary synovitis will be slightly elevated, and then we can also do an X-ray to validate joint deterioration, and an MRI may be used to determine vertebral or knee involvement. Okay, so let's discuss some medications. We can give Tylenol. It's usually the first drug of choice. We have a topical drug applications such as lidocaine, Aspercreme. You can have the COX-2 inhibitors or Celebrex. You may use NSAIDs, Flexeril, or Ultram. Physical therapy can include heat, paraffin dips, diathermy, ultrasound, and cold packs. Alternative therapies can include capsaicin, glucosamine, or knee injections. Goals of treatment will include to control pain, improve function, maintain normal body weight, and achieve a healthy lifestyle. Treatment indicates for exercise, weight control, rest and relief, non-drug pain relief, medications, and/or surgery. So let's talk about hip surgery. Total joint arthroplasty versus osteotomy. Contraindications for arthroplasty are active infection, advanced osteoarthritis, and rapidly progressive inflammation. Considerations are pain that interferes with sleep, limited ADLs, poor drug control, and patient will be able to participate in physical therapy after surgery. You will be checking for previous clotting, obesity, smoking, advanced age. They may need antibiotics such as Ancef. Anesthesia is bigeneral or neuroaxial. It is a minimally invasive surgery. Potential for dislocation, infection, DVT or PE, hypotension, bleeding, or infection. So you want to think about what the nursing interventions are for each, including medications. Some of the medications are low molecular weight heparin, Coumadin, and you want to be cautious because thrombocytopenia can occur. You want to monitor the CBCs and assess for bleeding. Protamine sulfate is the antidote. Atrixtra is an alternative, but there is no antidote. Most infections are caused by contamination during the surgery process. Older patients may not have a fever indicating an infection, but may have an altered mental state. Culture and sensitivity of the drainage is indicated. Surgical drains usually have less than 50 mL of drainage in 8 hours. You want to be sure to check the H&H. Blood may be needed 1 to 2 days after surgery. Cement can dilate blood vessels and cause hypotension. And they can do blood salvage via cell saver and reinfusion. For discharge teaching, the patient should have a 90-degree flexion and the patient can ambulate before discharge. Let them know there are complications of a DVT and an infection or bleeding. Other joint replacements are possible. You want to review nursing implications. Have them basically do exercises consistently, have them respect their pain, have them meet their safety needs, and have them decrease the number of reps when there is inflammation. For pain management, they may have limited one-day use of PCA. Then they have oral opioids, and then they may have different NSAIDs, which work better for some people than others. So they may need to experiment a little bit. Bed rest increases atelectasis and pneumonia, so for activity, they need to be up the day after surgery. You want to assist on the same side as the affected leg. You want to make sure that they stand on the unaffected leg and pivot to the chair. Partial weight bearing or non-weight bearing is usually ordered by the surgeon. Okay, we're going to talk about a total knee surgery. Expected life is greater than 15 years. It's a minimally invasive surgery. They will use a CPM. There are complications the same as a total hip, and there are also alternative therapies such as intraoperative insertion of Adelaide, and which causes extra calcium to enter the nerve cells, causing overload. But they do have less post-op pain. Let's discuss the continuous peripheral nerve blockage. It allows for quicker rehab and less pain. Do neurovascular checks every 2 to 4 hours. You want to check the plantar flex and dorsiflex. You want to check movement, sensation, warmth, color, pulses, and cap refill. And the med may be going systemic if they have a metallic taste, tinnitus, restlessness, nervousness, slurred speech, bradycardia, hypotension, respiratory decrease, and there are also possibility for seizures. Okay, so let's discuss rheumatoid arthritis. Let's discuss the pathophysiology. It is a chronic, progressive, systemic inflammatory autoimmune disease affecting synovial joints. It attacks healthy tissues, causing inflammation. They bind to antigens, forming immune complexes. Phagocytes attempt to engulf complexes and leads to cytokine release. Synovial membrane is first affected, then articular cartilage, joint capsule, and surrounding ligaments and tendons. Synovia thickens and becomes hyperemic. Fluid accumulates in the joint space. A pannus forms. Pannus is granulation tissue of inflammatory cells which eventually destroys the bone. Remission is possible. You want to prevent flares. Changes can be seen in organs containing connective tissue. Physical and emotional stress may be a trigger. Complications and manifestations that can occur are weight loss, fever, extreme fatigue, exacerbations, subcutaneous nodules, pulmonary and cardiac complications, vasculitis, periungual lesions, paresthesias, joint stiffness, low-grade temp. Upper extremity joints are initially involved and then it becomes bilateral and symmetric, migratory arthritis, subluxation of 1 to 2 vertebrae, Baker cyst, periungual lesions, and peripheral neuropathy. Lab work would include monitoring antibodies, ANA, anti-SSA, complement C3 and C4, ESR, C-reactive protein, culturally antibody test, CBC, WBC, and thrombocytosis is often common. Medications would include analgesics, antipyretics, anti-inflammatories, immunosuppressive, biological response modifiers, Plaquenil, NSAIDs, H2 blocking agents. Biological response modifiers most neutralize the biological activity of the TNF, preventing it from binding with its receptors. PPD tests must be negative, and it's not for use in MS patients. They may also use anti-rheumatic drugs, and then we have Rheumatrex and Erava. Physical therapy can include heat, paraffin dips, diathermy, ultrasounds, and cold packs. Okay, now we're going to discuss lupus erythematosus. There are 2 classifications, discoid lupus and systemic lupus. Anti-nuclear antibodies affect the DNA within cell nuclei. As a result, immune complexes form in serum and organ tissues. These complexes invade organs directly and cause vasculitis, decreasing oxygen and blood to organs and tissues. Skin involvement is polyarthritis, osteonecrosis, myositis, fever, fatigue, weakness, anorexia, weight loss, pleural effusion and pneumonia, pericarditis. Neurological changes include psychosis, paresis, seizures, migraine headaches, cranial nerve palsies, peripheral neuropathies, and serositis. Peritoneal involvement is you want to check for abdominal pain. For lab DLE, you will check skin biopsy for characteristic lupus cells and inflammatory cells. For SLE, similar to RA, RF, ANA, ESR, serum protein electrophoresis, serum complement and immunoglobulins, anti-SSA and anti-SSB, anti-Smith, and CBC will show pancytopenia. For medications, DLE, topical cortisone preps, and SLE, anti-malarial and Plaquenil. Tylenol or NSAIDs, steroids, immunosuppressive agents. May also use plasmapheresis and separation of plasma from the whole blood. Plasma is not returned and it eliminates the antibodies. You want to teach the patients to avoid sunlight and ultraviolet lighting, to have them wear sunblock and long sleeves, make sure they use mild soap, let them know alopecia is common, they need to use shampoos with proteins, and pregnancy can cause exacerbations. Now let's discuss scleroderma. The pathophysiology includes: it can be localized or systemic, limited or diffuse. It is not always progressive. It is less common than lupus but has a higher death rate. Inflamed tissue that becomes fibrotic and then sclerotic. And renal and respiratory complications are common, and so is hypertension. Clinical manifestations include arthralgia, painless symmetric pitting edema of hands and fingers, skin is taut and shiny, and organ damage to the GI, cardiovascular, pulmonary, and renal. Collaborative care will include steroids and immunosuppressants, use of mild soap and lotions, a bed cradle, also known as a footboard, and then warm room temperature. Avoid cigarette smoking and stress. They may need a swallow study. And you want to encourage them to eat small, frequent meals. Okay, so you want to watch for Crest syndrome. C for calcinosis. R for Raynaud's. E for esophageal dysmotility. S for scleroderma of the digits. And T for telangiectasia. Now we will discuss gout and fibromyalgia. Gout is a systemic disease in which urate crystals deposit in the joints and body tissue, leading to inflammation. In an acute form, it gives patients so much pain they seek help immediately. It's often located in the great toe. We will check serum uric acid level, and medications can include Cosalide, NSAIDs, allopurinol, a combination medication, and then aspirin should be avoided, and they need a low purine diet. In fibromyalgia, it is a chronic pain syndrome and is not inflammatory. Trigger points where the pain is reproducible in the back of the neck, upper chest, trunk, low back, and extremities. It is thought to be an inability to tolerate the pain or dysfunction of the brain. It's most often found in women ages 30 to 50. One of the drugs of choice is Lyrica, and it's been the first drug that was approved for treatment. This concludes the lesson of arthritis and other connective tissue diseases. If you have any questions related to this lesson, contact the instructor.